Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Yasser, for inviting me. I'm going to talk about living with CKD, cardiovascular disease. Now we all know that there is a very close relationship between the heart, the kidney, and the blood vessels, and commonly when one is affected, the other is affected. And the incidence of cardiovascular disease in patients with CKD increases as GFR progresses. And although patients with CKD are usually afraid that they will reach the end-stage renal disease and require renal replacement therapy, they are actually more likely to die from cardiovascular disease than to reach end-stage kidney disease. We'll take a patient. This is not the picture of a real patient. This is an AI-generated case picture. He's 63-year-old. He's presenting to the emergency department complaining of progressive dyspnea, paroxysmal nocturnal dyspnea, orthopnea since 2 weeks, progressive generalized edema, fever, cough 3 days ago. His past history, he's a smoker with a PAC-year index of 30, diabetic, hypertensive since 10 years, chronic kidney disease discovered in his routine follow-up 4 years ago. He is on a triple fixed dose combination of ARBs, calcium channel blockers, and hydrochlorothiazide, sulfonylurea, glycoside, dapagliflozin together with metformin XR, and he is on atorvastatin 20 milligram once daily. On examination, he is obese. He's hypertensive with a blood pressure of 150 over 100. He's tachycardic with regular pulse, congested neck veins. He is in respiratory distress with firm pitting edema in his lower limb, scrotum, and sacrum. And he has bilateral basal to mid-zonal lung crepitations. His latest investigation 3 months ago was that his creatinine was 1.6 with a GFR of 48.1, so he's stage G3A. He has a urinary albumin creatinine ratio of 1,450, so he's A3. His potassium is 4.8. His hemoglobin A1C was 7.5%. Total cholesterol 210, LDL at 110, and HDL at 30 milligram per deciliter. On admission, his creatinine has risen from 1.6 to 4.3 with a current GFR of 14.7. His CRP is elevated at 120. His hemoglobin is at 8.4 grams per deciliter, although he did not have previous anemia. White blood cells, 18,000. His serum bicarbonate was 15, and his serum potassium was 5.8, and the random blood sugar was 280, but he did not have ketoacidosis. His cardiac enzymes were elevated, but there was no progressive increase, and ECG showed sinus tachycardia with signs of old anterior MI and no signs of acute myocardial infarction. His echocardiography showed ischemic cardiomyopathy, biventricular dilatation, and systolic dysfunction with hypokinesia of the anterior and lateral walls, ejection fraction of 30%, and moderate mitral and tricuspid regurg. So the first question, was he adequately treated for prevention of CKD, given these parameters? Adequately or not? No. Why? There are multiple things that were not controlled. Blood pressure? His hemoglobin A1C was not controlled. His albuminuria was high. His LDL was elevated at 110. Ideally, in patients with at severe risk for cardiovascular disease, it should be below 70 or even below 55. What would be the change in the medications? So sulfonylurea is not beneficial, but he's already on the guidelines. What would be a better option in this patient? I would not say insulin, because again, it's not the best option, but it is an option. But actually, by the guidelines, the best option for this patient, because he's obese, because he has CKD and proteinuria, would be GLP-1 agonists. Yes, and the atorvastatin should be raised. So if we look at this picture from the KDIGO 2024 guidelines, which I think every nephrologist should memorize by heart and should stress on at every visit for every patient, we first should abide by the lifestyle interventions, and we should remind patients every visit that they should stick to a healthy diet, try to lose weight and maintain a healthy weight, stop smoking. He's also a smoker, so this should have been approached by his dietitian. She should have physical activity. The second thing is the control of his diabetes. He should be at target, and maybe the best option for him in this case would be incretin mimetics together with the SGLT2 inhibitors he's on and the metformin. The second thing is controlling blood pressure. Yes, of course, now it will change and it's coming that we have to stop it. The second thing is control of the blood pressure, although the KDIGO recommend that the systolic blood pressure should be below 120. I think this is too aggressive and may not be applicable to every patient. And it's based on standardized blood pressure measurement, but at least he should have a blood pressure below 130/80 with the maximally tolerated ARBs. He is at olmesartan 20 milligrams, so it should be actually, we prefer to raise it to decrease his proteinuria and maybe decrease the calcium channel blocker and the other antihypertensive treatment. And if not effective, actually for him again, non-steroidal MRA by the guidelines, because they will add to the antiproteinuric effect, will be a good option. For cardiovascular risk, he should be on moderate to high intensity statin based on either the cardiovascular disease risk or the lipids, and both are not controlled, as we'll see in the next slide. So his lipids are not well controlled. He should be on high statin. So high statin is what? High intensity statin. Either atorvastatin 40/80 or rosuvastatin 20/40. We do not prefer rosuvastatin because at the GFR below 30, it should not go higher than 10 milligram. So actually a better option would be to put him on atorvastatin at a higher dose. Antiplatelets like aspirin are not recommended anymore for primary prevention. They're only recommended for secondary prevention in a person with previous cardiovascular disease. Adding other anti-dyslipidemic drugs should be done if there is remaining risk after after high intensity statin. And what we frequently forget is that we should also look for and manage other chronic kidney disease complications like anemia and CKD, MBD, which also raise the cardiovascular risk. So maybe his anemia should also be investigated, and Dr. Zogby has told us about how to approach this. Now, this is the atherosclerotic cardiovascular disease risk score and how we should treat it. Actually, so chronic kidney disease is considered the risk equivalent, and any patient with chronic kidney disease, this, even without calculating the risk score, is considered to have high risk for cardiovascular disease. But actually, if we calculate the risk for this patient, given the results of his investigations, the previous results, he has a very high 10-year risk, put him at high risk, and indicating that he has take a high intensity statin. Of course, this risk, the main drawback of it in chronic kidney disease patient is that it does not take the non-specific or the non-traditional cardiovascular risk factors that are associated with chronic kidney disease like CKD, MBD, anemia, vascular calcification. And actually, that's why any patient with chronic kidney disease should be considered at high risk. The second question is, there was nephrology consultation. What's your diagnosis? Is this progression of chronic kidney disease AKI due to sepsis, AKI due to acute decompensated heart failure, due to the medications he's on, or a combination? It's probably a combination of all. So in any patient with heart failure and elevated renal function, whether it is acute on top of chronic or acute kidney injury, we first have to think of acute heart failure that can cause acute kidney injury in multiple ways, especially if there are predisposing factors like diabetes and CKD. But also, this could be true AKI due to sepsis or AKI because of not abiding by the sick day rule, which we should educate our patients about, that whenever there is acute illness like his fever he had, that he should decrease his the medications that increase the risk of AKI, like what? ACE inhibitors or RAS inhibitors in general, metformin, and SGLT2 inhibitors, and he was on 3 of these drugs. So the first step in any patient with worsening heart failure would be to exclude non-cardiac etiologies and check the volume. Is he congested, dehydrated, or normal? And the first step would be to correct any non-cardiac etiologies. So in this patient, what would be your next step? Which medications would you stop and which medications would you start? Would you stop olmesartan? Yes, okay. Actually, olmesartan in heart failure is not included in the guidelines, and the ARBs that are included do not are candesartan, valsartan, and losartan. Amlodipine, would you stop it? It does not have a beneficial, neither a harmful effect, and he's hypertensive, so we can continue it. Would you stop hydrochlorothiazide? We could stop it at first. Glyclazide, yes. Dapagliflozin, yes. Metformin, of course, his GFR now is below 30. Which medications would you start? IV diuretics? Yes, it is indicated. He is congested. Metolazone or other diuretics together? Maybe not initially, but if the patient is resistant to IV diuretics, and we're going to see the algorithm that the European Society of Cardiology recommends, would you start ARNI? Not at this point, but maybe later, because his GFR is low. Beta blockers, yes, there is no contraindications. He has tachycardia and hypertension, and they will be beneficial both for his heart failure and for control of his blood pressure. MRAs or non-steroidal, again, not at this point. Digitalis, nobody uses it, and he has also acute kidney injury. Antibiotics, yes, he is indicated in this patient. So, how should we approach a patient with AKI who is on RAS inhibitors? First, we should determine whether he has fluid overload or is he hypotensive or infected. If he has fluid overload, we should start with decongestion and diuretics, and patients often need high IV dose of diuretics. We could start with a bolus and continue with IV infusion, or depending on the response of the patient. If he has heart failure with reduced ejection fraction, they do not exactly say that we should stop it, but we could stop it if there is progressive increase in renal function because of its benefit. If he has heart failure with preserved ejection fraction, there is no prognostic benefit of it, so it should be stopped. And if the patient has hypotension or infection, it should be stopped. And whenever we stop RAS inhibitors, we should remember that once the patient has recovered from the AKI, we should restart it again. So diuretics, of course, here they should be parenteral, and there is no difference actually between continuous and infusions, or at least twice daily, and but not once daily doses should be avoided. And actually, there is no clear benefit between furosemide and torsemide, whether in heart failure or in CKD. The European Society of Cardiology recommend how we approach the management of or the diuretic use in acute decompensated heart failure. If the patient was on oral loop diuretic, we should start at the oral dose 1 to twice per day. If he was not on oral diuretics, we should start with 20 to 40 milligram IV. In patients with CKD, we say we should double that dose, and we should monitor the response, and they recommend that we monitor the response either by measuring the urine spot sodium or the urine output after 6 hours. It should be within 100 to 150 milliliter per hour. If we're not at target, we should increase the dose gradually and until we reach the maximal dose, and the maximal dose is, they recommend that it's from 400 to 600 milligram furosemide, or half that dose if we're giving torsemide. And in patients with CKD, we can increase that up to 1,000 milligram per day. And again, continue to measure, to look for the response. Is the urine output reaching that amount, or is the urine, or if we can measure the urinary spot sodium, is it at target or not? until we reach complete decongestion. If not responding, then at that step, we should use combination therapy. And actually, there is new evidence about not only combination therapy with metolazone, which we usually do, but actually there is evidence that thiazide diuretics can be used, and that acetazolamide, especially if the patient has some alkalosis, can be used and is effective even in patients with CKD up to a GFR, I think, of 20 or 30. So the patient was admitted to the hospital. He was given furosemide bolus, then infusion. His urine output improved initially, but his urine output was 50 to 100, so metolazone was added. He was given broad-spectrum antibiotics. However, the dyspnea progressed, and his creatinine increased from 4.3 to 5.2. So, as we said, metolazone was added, but again, the urine output did not improve, and renal function rose to 6.7. In that step, what would you recommend? So, if the patient is not responding to diuretics at maximal dose, and there is also another indication for dialysis, maybe the best option in this patient is to do dialysis with ultrafiltration. So this patient actually was given 4 sessions, each with ultrafiltration of 2-3 liters. Now, AKI later in the hospitalization of patient with acute decompensated heart failure, maybe because of initiation of RAS or other goal-directed medical therapy, and in this case, if it is below the 20 to 30% recommended, we can safely continue the treatment and not worry about it. It can be because of aggressive decongestion, and if the patient is reaching depletion, so we should look at the patient as a whole. Is he being decongested at an acceptable rate? If the rate is too high, we should reduce the rate of diuretics. If he's not being decongested, maybe we should, it's not working, and we should either change to ultrafiltration or increase. But we should, in all cases, exclude dehydration. And if it may be true, worsening renal failure or AKI, in this case, as he has also sepsis together with his case. And in all patients, we should always try to keep them in the optimal status, not at the overhydration and decongestion where the heart will not be functioning well, and this may lead to decreased perfusion of the kidney and worsening of the renal function. And again, avoid reaching to excessive diuretics and rapid decongestion, leading to dehydration and also AKI. So back to our patient, during the second week, his infection started to subside. His white blood cells and CRP dropped, his dyspnea and generalized edema improved, and his urine output improved. Dialysis was stopped, and on low dose of furosemide, his urine output was 2,000 to about 2 liters to 3 liters per day, and his creatinine started to drop without dialysis to 4.4. What would you give? So he was being planned for discharge. What would you prescribe at discharge? So should we start goal-directed medical therapy at this point? Or which of them can we start? So can we start RAS or ARNI? Not still. He's still at GFR, although it is approved from stage 1 to stage 4, but it's difficult to start at stage 5 unless the patient is already established on dialysis. Beta blockers, they are safe and can be continued. MRAs, again, because of the risk of hyperkalemia. Would you start SGLT2 inhibitors? Would you start this? So,
yeah, I mean, his GFR is pretty low at this point. I would be hesitant. I mean, if he was already on it, I would continue probably, but at this level of GFR, I would be very worried.
So far, the guidelines have said that below 20, we don't prescribe it.
I also want to comment on this. I mean, it's very unlikely that that will have any hemodynamic effect, though, because we know that with the very low GFR, there is reduced glucose excretion, likely sodium excretion, and we know from the CKD stage, from DAPA CKD in people with CKD stage 4, that there is no increased side effect. So there are studies now in people who are on dialysis using SGLT2 inhibitors or also pre-dialysis. Like this, there is a study of dapagliflozin that is looking at people progressing to ESRD on dialysis and then post-transplant, all of them using the same SGLT2 inhibitor. That will give us more information. But I think if we truly believe that it has anti-fibrotic, anti-inflammatory properties, then I'll probably restart low dose and monitor.
So Actually, I have not heard it, but I've heard that in the latest ASN there was a first reveal of the DAPA advanced CKD, which used up to a GFR of 10, and actually the results were positive. They have not been published yet, but till now, in a GFR below 20, we should not start it, but maybe once it's published and once it's...
He was on that, right? I mean, he was on that, was held. We are not really starting it because he was on the SGLT2 before.
But we stopped it when he was admitted, so should we start it now or later? Maybe I would wait. I would not start it at this point. And of course, he should be continued on diuretics. So the 4 foundational pillars that should be recommended, and the European Society of Cardiology recommend that they start in all patients simultaneously, are the SGLT2 inhibitors, ACE inhibitors or ARNIs, and ARBs only if they are not tolerated, beta blockers, and MRA. And they are recommended by the European Society of Cardiology as well as the American Cardiology, American College of Cardiology as first line, class 1, together with diuretics. However, there is a risk with all of them, except for beta blockers, of increase in creatinine, of AKI, of hyperkalemia, and actually patients with severe renal dysfunction were excluded from most of the pivotal trials that recommend them in heart failure. And actually, we find this very common that we say something and the cardiologist says something, the cardiologist wants to start them right away, we want to delay. And patients with this condition, they are often frail, they have multi-morbidities, and they are on many medications that may interfere with them. And that's why many of our patients who are CKD and heart failure do not receive enough of the guideline-directed medical therapy. But it's just about knowing how to give them and how to monitor the patients. So this is an algorithm in one of the papers that was based on the European Society of Cardiology guidelines that sets based on the GFR which goal-directed medical therapy we should start. Our patient is in the GFR below 15. They actually recommend that we only initiate monotherapy using beta blockers. And something that they recommend, both the American College of Cardiology and the European Society of Cardiology, that they recommend whenever ACE or ARBs are not recommended, but we're not using it enough, is the hydralazine together with dinitrate. And there are fixed combinations, I know, in elsewhere. Actually, here we have the dinitrate, but we don't. Hydralazine is not always available. But actually, it should be the second option for patients with heart failure if they cannot be given ACE inhibitors. And actually, it's also if they are on ACE inhibitors and all the goal-directed medical therapy and they're not improving, it can be added on top of the other GDMT. And actually, they also recommend that we can start ACE inhibitors at a low dose. And presence of congestion means that we should use diuretics, but at the discretion of the physician. So we should always revise the definition. Actually, at this point also, as Dr. Zoghbi has said, and something that we can use in all patients with CKD, however the stage is the use of iron. And although most of the studies that studied the outcome of iron infusion in heart failure used the newer ferroxylate and carboxymaltose, which are not available in Egypt, actually this trial included 2 studies on iron sucrose, and they found that iron infusion in patients with iron deficiency and heart failure was associated with lower mortality, lower hospitalization, and better outcome in patients with heart failure. So actually, in all our patients, we should look for iron deficiency and treat it if it is present together with heart failure. And after infection has subsided. So this is, we're talking about, this is a good point, of course, and that's why I talked about it after his improvement. We should, of course, his anemia may have been partly because of his infection. We should reassess it and reassess his iron profile. And if he is iron deficient, one of the measures to improve his heart failure would be to start him on iron infusion.
I just want to do one more comment. So I think we talk about all pillars, and then we are recommended to keep prescribing to our patients, whether they're like 4 medications, now 5 medications, now iron, whatever that is, then soon enough phosphate binders. So there is a lot of polypharmacy going on, and we do not know how our patients cope with all those medications, including cost and side effects. But I think one thing that is really missing is that aggressive weight control. And this person has been progressing with his CKD and has developed severe obesity complications. And he has a lot of visceral fat, I can tell from his picture. So I think in the beginning of his journey, aggressive weight management, now we have GLP-1 receptor agonists or GLP-1 GIP should be implemented, and if not tolerated, then he should be considered for bariatric surgery. I have a lot of experience because we do bariatric surgery in our people with very advanced CKD who are kidney transplant candidates, even with improvement of the kidney function after bariatric surgery. And then in the earlier stages has been, shown over and over, so he probably wouldn't have developed a heart failure, renal failure, worsening of diabetes, maybe obstructive sleep apnea that he probably has looking at his, physique here, and other complications if he was, very aggressively managed.
Yeah, great. I enjoyed this presentation, and thank you for this comprehensive review. Just another comment as well. As you know, the guidelines are very helpful, but they remain guidelines, right? And you have to always individualize it for your individual patient. So one comment is regarding, the use of MRA, which is typically not used when your GFR is low. But again, there's always exception. And so one example I had last year was a patient, very similar situation with a lower EF. But he had primary hyperaldosteronism as well, hyperplasia diagnosed, confirmed with hormonal studies. And I couldn't control his blood pressure until I introduced MRA. His GFR was 25, so I was very hesitant, and his potassium was borderline. And I had to start very low dose aldosterone, and eventually start increasing the dose, which really got his blood pressure under control, but then his potassium went up. So we had to, do this dance and balance things out. And eventually I kind of was able to keep it on and control the blood pressure. But, you have to carefully monitor this patient very closely and make adjustment and fine tune it.
Yeah, I have to confess that we are also sometimes use it, especially in patients with heart failure who have hypokalemia, to improve their hypokalemia. So there are exceptions, but
Thank you, Professor Yasmine, for this highly elegant case presentation. Professor Zoghbi and Alexandra for comments. My comment is about that reintroduction of medications and rise of serum creatinine with heart failure. We look at the kidney. We all as nephrologists look at the kidney, but the heart is important. And cardiologists have the rights in keeping their heart. So we are to differentiate about this AKI or real function of the kidney and what you said, worsening of renal function with drug medications. And the tubular function you said is the very important point to discriminate between both. We have good tubular function. Is this some rise due to drugs and we are to tolerate due to preserve the heart, or the actual syndrome of acute kidney injury being progressive, being affecting urine output, being really affecting GFR. So we are to balance this, not to look from, this is for the juniors, not, you said it, but I would stress on that point. The heart is also important as the kidney in protection, not look one side. Thank you.
So I agree it should be a disciplinary approach. Okay, so it was so he was started on amlodipine, carvedilol, torsemide, aspirin, atorvastatin, and basal bolus insulin. And he presented 2 weeks later with a reduction in his creatinine. His GFR now was 31, so it has improved. And he's now at 3B, potassium 5.1. His edema is mild, and his chest is clear. His actually GFR has improved to 35%, and the only trace mitral regurg. Would you start now a goal-directed medical therapy, or would you wait till he returns to his baseline? Start. Okay, and which would you start? So RAS inhibitor or ARNI? So there are better results with ARNI, and it may be better tolerated in chronic kidney disease because the valsartan is lower. Would you start MRA? Maybe after starting ARNI to check for the development of hyperkalemia, would you start SGLT2 inhibitors? Yes. Start immediately or sequentially? So although the guidelines recommend that we start immediately, I would go also sequentially. And would you maintain the diuretic dose? Reduce the diuretic dose. We should always revise the diuretic dose when starting MRAs, SGLT2 inhibitors, or ARNIs. They have diuretic effect. And if the patient is dry, we should consider, can I have two? I'm going to go through the remaining slides very quickly. So we should, in this case, because we are starting SGLT2 inhibitors, we should maybe gradually withdraw the diuretics. And diuretics are one of the drugs that I recommend that all patients use self-management. So I usually tell patients, if you're dry or if you can weigh yourself and check if there is your weight is stable and is not increasing, you may gradually try to reduce your diuretic dose and maybe increase it if there is an increase in the edema or an increase in the weight. Of course, I'm not going to discuss this, ACE and ARBs. There are recommendations to check for hyperkalemia, check for increase of more than 30%, and this also should be applied if we're starting ARNI, and we should try to reverse it, and if we cannot reverse it, then we should stop it. Also, we have to take care of the recommendations when starting SGLT2 inhibitors. If the patient is at or below target, especially if he's on insulin or sulfonylureas, we should decrease their dose to avoid hypoglycemia. And if he is dry, we should look for reducing the diuretics before starting it. As for mineralocorticoid receptor antagonists, actually most studies about mineralocorticoid receptor antagonists were in patients with normal GFR. Only the finerenone was studied in patients with lower GFR, the studies about heart failure. And if we're going to start finerenone, I think it can be a later step. And in finerenone, we should again follow the guidelines on how to monitor potassium. So actually here they recommend that we start beta blockers as and after that, we can recommend initiating MRAs and start titration. Actually, they have different, Fadili, one only slide. We should, they recommend that we do not stop it unless there is an increase by 50%, not the usual 20 to 30% we recommend. But actually, there is a fine print. It's not if the increase in serum creatinine is less than 50, as long as the creatinine is less than 3 milligram, or a drop in GFR of less than 10%, unless provided the GFR is above 25. So whenever the cardiologist said, no, we should continue it, even if there is a rise of 50%, the creatinine should not be more than 3. And in the end, it should be a multidisciplinary approach. We should carefully address these drugs and gradually use them. Thank you.